Welcome. I'm Lawrence MacDonald, Vice President of Communications here at the Center for Global Development. My guest today is Tom Bollyky, newly arrived visiting fellow here at the Center for Global Development. Tom is a lawyer by training and has worked most recently in the Office of the U.S. Trade Representative, where he represented the United States in negotiations with Korea and China. He's unusual in having worked on both sides of what is normally an unbridgeable divide in the contentious, often contentious issue of access to drugs and the role of the law in restricting or increasing that access. Tom, what led you to get interested in the issue of global health policy on the one hand and the intersection with law and ethics and regulatory affairs on the other?
That's a great question. First, thanks for having me here today. I became interested while I was in law school, actually. I had worked in both the New York City Department of Health and at the Department of Health and Human Services prior to going to law school. But around my third year of law school, I had seen an article, this is around 1999, I had seen an article about the South Africa treatment access crisis. And for me, somebody who had been studying international trade, intellectual property, but also health issues, this seemed to be a problem that had a solution. That it seemed that if you could align government's incentives, industry's incentives, and patients' interest, you could find a middle ground that would allow patients in the developing world to have access to medical technologies. South Africa at the time had one of the fastest growing HIV epidemics of any country in sub-Saharan Africa. And at the time I was there, I eventually ended up going to South Africa as a Fulbright scholar after clerking after law school. And at the time I was there, only 20,000 South Africans had access to antiretroviral treatment, almost entirely through the private sector, so wealthier individuals. At the time, I think there was roughly in the area of around 4 million South Africans who were infected with HIV/AIDS. Obviously, these numbers call for some sort of solution.
But why was that a legal problem? I would have thought this was a problem of funding or not enough clinics or infrastructure. What was it specifically about the law that was part of the solution?
It's a good question as well. It's not all of it is a legal question for certain. There is a lack of resources or a lack of money that come into play, but the pricing of products at the time in South Africa were really along the lines of what the pricing of those products were in the US or Switzerland. Of course, South Africa at the time, the average individual, particularly the individuals, it's not surprising to anyone that infectious disease and poverty are correlated. The individuals who had HIV really didn't have access to these treatments. Fueling that, of course, is the vast majority of treatments at that time were patented in South Africa. So therefore, the pricing, the companies selling the products have a right to exclude other products that would otherwise make or use their intellectual property, and therefore had somewhat of a monopoly on the ability to sell those products. So prices were high at the time.
Were you able to use the law to actually bring prices down?
We were, over time, law as a tool for pressure. In that context, I was involved in a case before the South African Constitutional Court involving prevention of mother-child treatment, which involved the use of nevirapine. Through the threats of other suits, there was an antitrust litigation at the time that put a lot of pressure towards lowering the prices of pharmaceutical products, and from that sense, law did have an active role to play in reducing the prices and increasing the accessibility of drugs in South Africa at that time.
One of the things you mentioned to me when we were chatting is that the big public-private partnerships and the funders of global health issues had very few lawyers on the staff. In preparation for this interview, I went back and looked up the famous Shakespeare quote from King Henry VI. The first thing we do, let's kill all the lawyers. Is there kind of anti-law bias inherent in some of these groups that they don't have more lawyers on the staff?
Lord, as a lawyer, I hope not, but it's always possible. But I think it's more that, of course, there are large public health components to this work and scientific components to this work as well. And I think people just haven't really realized the central role that law and ethics play in these processes. Let me talk a little bit about that. Law and ethics really define, you can look at it into two categories in terms of their effect on these processes. Law and ethics really define the incentives and the liabilities and the processes by which drugs and vaccines are discovered, developed, and delivered to patients. That is, in terms of incentives, a mixture of public and private arrangements, spur R&D. When I refer to that, that's intellectual property or tax or regulatory incentives, or public or private grants, spur research and development. Law and ethics also define the processes by which the safety and efficacy and quality of products are defined through clinical trials or around manufacturing. They also give regulatory authorities the ability to enforce those requirements. And last, law and ethics define the pricing and procurement of products. So that's really the first category. The second category that law and ethics play in this is that they coordinate the investments and activities of all the entities that are involved in the discovery, development, and delivery of drugs and vaccines to patients. So starting from the small biotech or the university that develops the technology to the larger pharmaceutical entity that might collaborate with that small biotech or university, or the public-private partnership that might form a collaboration around that research and development, all the way through the entities that conduct the clinical testing, the wholesalers, the retailers, all the way down to the patient. And defining how those relationships work, or better ways of increasing the efficiency of those relationships, would do a lot to improve the time and the efficacy by which drugs get to patients.
Tom, I want to unpack that a little bit, because for many of our audience that'll be rather abstract. And I'm thinking in particular of a report that we did here at the center, the Advanced Market Commitment for Vaccines. And I know you weren't involved in that, but you mentioned to me when we were chatting yesterday that this report, and in particular the term sheet that's in the back, the sample contract by which the sponsors would commit to buy in advance a vaccine that does not yet exist, has been very instrumental in bringing this idea from the realm of ideas into action. Can you talk to us about that?
I think this is a great example, first of all, of the Center for Global Development's work, and is one of the reasons I'm proud to be here and involved in the project that we were talking about today. I think what characterizes the advanced marketing commitment as a good example of what we're discussing is its early use of law and lawyers in terms of thinking about how to structure the incentives, the liabilities, and the roles of the various entities involved in producing a vaccine from an early stage. So the advanced marketing commitment is defined by a series of contractual arrangements between the developer, the supplier, and the funder in this case, as well as the hosting organizations for the marketing commitment. The problem that you're trying to solve with an advanced marketing commitment is there are not sufficient economic incentives to produce vaccines for certain developing world diseases. By having a commitment to pay, to have a co-payment around the supply of these products, you provide an incentive that would not exist in the private market for producing these products. The thing that was so wonderful, the aspect that was so wonderful about this work, was the recognition of the legal expression of that commitment, of that incentive, has everything to do with its efficacy for the entities that will be involved. So how you, whether the arrangements are binding, which entities have what roles and what incentives and what liabilities and indemnification, all these things, of course, in the private sector are exactly what are thought through at an early strategic stage to create the incentives to reach the outcome that all the parties involved really want to reach. But what you'll often find in a lot of global health contexts, mostly because of resources involved, is that there's not the opportunity to really think about these issues in advance. And I think that advanced marketing report is a great example of the case where that was used in that way and has been very successful. Not only has the project gotten off the ground, But really, the work that was done in that report, as you said, bears a very close resemblance to what the actual product ended up being 3 years later.
Tom, this will be my final question. In closing, I want to put you on the spot a little bit to describe for us a particular problem where greater attention to the legal framework could have made a real difference to poor people in the developing world.
So a lot of public-private collaborations to produce products are starting to produce those products. A good example is a few years ago with artemisium-based malaria treatments. Now, the problem with supplying or developing a product for the global health context is that currently you have to go through regulatory processes in a number of different jurisdictions. You may be the country in which the product was originally developed, as well as multilateral regulatory processes, as well as the in-country regulatory processes. There's a lot of overlap. The requirements can often be inconsistent, and they often change. This adds real time to the process of development of important products that can save patients' lives. So in, for instance, the demand forecasting report that CGD did a couple of years ago, there's a great chart that references that products, these artemisium-based malaria treatments, getting out into the market were delayed as much as 1.5 to 2 years by these overlapping regulatory processes. For patients, a 2-year delay of being able to access these treatments means real patients' lives. This is a good example of an area in which strategic, proactive, holistic thinking about the legal requirements of how this regulatory architecture is set up would allow you to potentially streamline and shorten that period of time, get drugs out to patients more quickly, and save more lives, which is really what the goal is.
Tom, it's a real pleasure to have you here. I look forward to working with you, and welcome to the Center for Global Development.